Okay, I hope I have this correct. Hello, it is Thursday, May 14th. I am Dr. Regina LaRocque. I'm a board member of Sustainable Wellesley, and I'm also a physician at Mass General Hospital. I specialize in infectious diseases, and I am doing these Facebook streaming events to answer questions for people in town and to make myself available. And I'm getting some sense that I've done it correctly because I'm getting some messages here. I just want to say, first of all, that I'm here just representing myself and giving my own experience and perspective on what's taking place. And I don't represent any of the organizations I'm affiliated with. I wanted to actually change the plan and try to make a routinely scheduled time to be available. So I'm going to try to do this every Thursday night at 7, and hopefully I'll be able to sustain that. So I have a couple of questions in front of me, and I wanted to try to see if I could respond to some of this stuff that might come in on the stream as well, and I'll do my best to do that. So it might be worth, maybe just since I haven't talked in a couple of weeks, to just give a sense of where things are from what we've been seeing here in the Boston area with COVID. So I'll just say that there is, I think, I feel a change in the mood in the air. I think people are feeling fatigued by the lockdown scenario that we've all been experiencing, and that is certainly understandable. In terms of what we've been seeing in the hospitals, there certainly has been a long, high plateau that has been gradually decreasing, although we still have many people hospitalized at my own institution and others in the state in intensive care. I was just looking at the dashboard from the Department of Public Health, and there's more than 750 people in intensive care units around the state. So that is still a very significant number of very ill people. I think the other clear event that has transpired in the last couple of weeks is we've seen that there really has been a very discordant degree to which different communities have been hit by the pandemic. The communities with a lot of working people in Chelsea, Revere, Lynn, Lawrence have been hit very hard and are continuing to experience really high rates of infection and illness and death. And it is disproportionate to communities like our own, here in Wellesley. And I think it's really emerged that is the story of the infection, that some people are experiencing it to a much more severe degree than other communities, and there's a real crisis of equity going on as well. And there's a lot of reasons why certain people are more prone to become infected and also more prone to become ill when infected. I think we know that not everybody has been able to, either by choice or not, participate in the types of safeguards that we've had to put in place to protect ourselves. Many people, due to the nature of their work, are unable to protect themselves from infection. They're not able to work from home. They have to take public transportation. They do work in types of employment that necessitate frequent contact with other people. These are reasons why it's unavoidable to be more exposed. And then certain people are more likely to get very sick when they are exposed. So we've come to see a lot of the risk factors for severe illness have become clearer, and those include underlying illnesses that tend to track with your zip code as well. So diabetes, obesity, smoking. So I think the story of COVID is the story of how unequal the health of different communities are to begin with, and it's pretty well known to those of us in medicine that the zip code where you live is the best predictor of how healthy you are, and that continues to be the case even now. I think that the other thing that has evolved in the landscape over the last couple of weeks is the introduction of one medication that has promised the possibility of treatment. That's remdesivir. There's a number of vaccines that are being studied. We've had an expansion of the types of tests that are available, both molecular tests for the virus itself, and then there's been a lot of interest and talk in antibody testing for coronavirus, and that is a complicated topic and a confusing topic for a lot of people. And I could talk about that if that's proves to be an area of interest. And then I think the other big change here in Massachusetts and around the country is the beginning of discussions about what it looks like to relax some of these safeguards and to begin to open up. And how do we do that? And how do we do that safely? And when is the time to do that? And those conversations are beginning to happen here in Massachusetts as we speak. So that's kind of what's been transpiring over the last couple of weeks. So I'll answer some of these questions that I have in front of me. And so I'll start with one that's a little simpler. So the first question just relates to, I guess I must have mentioned in one of my previous talks a question about whether it's okay to eat uncooked food. So I'm just wondering what you think for your family with regard to uncooked food. So I think that I may have mentioned that long ago, but I guess I want to emphasize at this point that it's pretty clear that coronavirus is transmitted through person-to-person contact with people who have infection. So through droplet spread or potentially more potent spread, aerosol spread. So it's really contact with other people that is the main driver, and frankly also potentially contact with surfaces or objects that people's droplets have landed on. So those are the main things that we really should focus on, and I want to emphasize that at this point it's become quite clear that the routine facial covering is going to be a very important component of how we protect ourselves in the coming months while we wait for a vaccine to become available. It is now, mandated or ordered in the state. It's been recommended for everybody by the CDC, and just from first principles, it really is an important component of what we're going to need to be doing routinely to safeguard our neighbors and our community. So it's a behavior change that we have to model and that we have to encourage everybody to participate in. And I think one really key reason for this is that there's clearly transmission from people who are asymptomatic, who have no idea that they're infected. And so the only way that we can get a handle on that is for everybody to be covering their face so that they're not inadvertently infecting others. And so the reason to cover your face is to protect other people. It's not to protect yourself, although it has that benefit by discouraging you from touching your face and nose and things like that. But the main reason is to protect other people. So, it's fundamentally about how we exist in a community and how we protect other people. So I'm not so worried about uncooked foods. I'm really more worried about people regularly covering their faces. So somebody's asking about my thoughts about opening up, and so I guess I'll comment on that a little bit. And I think this is probably my thoughts are really local to our own experience in Massachusetts. So, I think it's a really understandable interest and a conversation that we all have to be having, because, the situation we've been placed in where we've had to kind of lock ourselves down is, of course, not sustainable for the long term for anybody. On the other hand, we have to recognize that this virus is really driving the decision making, and I think that nobody wants to give up the gains that have been made by the tremendous sacrifices that everybody has made if we move too quickly and don't ensure that we're moving forward in a cautious way. So in terms of what's happening here in Massachusetts, I mean, I will acknowledge that I have concerns. I have very serious concerns about what the next week holds for us. I think I'm concerned because the date of May 18th has been kind of set, I think, in people's minds, because that is when we are going to hear the governor's plans for reopening. And I believe that people having that date in their mind seems to have anchored them on the idea that is the day. And frankly, as I look at the data, the number of deaths and the number of cases and the amount of testing that we're doing right now, the data don't really point to May 18th being a particularly good time to make any big move. We continue to have very high number of deaths. We have 5,500 deaths in the state, which is more than the entire country of Canada. And we have really not enough testing capacity or ease of testing. And so I think the numbers at this point don't, although some components of them are promising, the numbers as they are now don't suggest that we have really tamped this down. And so that's a concern. A second concern I have is that I feel that, these are really big decisions for all of us in our society, and it's important to be transparent about the decision-making process and to be inclusive. And I'm concerned that it's a bit of a black box, what's going on. I think some of that relates to the nature of how, could we have had a public hearing on any of this? It would have required a little creativity to broadcast, but these have not been public conversations about what's going into the decision making. So I feel like there has been not enough transparency about what information is being fed into the decision making process. I'm also concerned that the people who are at the table in the decision making process that I see proceeding are not representative of the entire state. Not representative of the stakeholders, particularly the workers who have been most affected by this. And I also am not sure what health parameters are being applied to the decision making. To my mind, it would be quite possible to ascertain some very sharply delimited numbers of what you want to see happening before you move on to a next step. And we haven't seen those yet. So I have concerns about transparency. I have concerns about inclusivity. I have concerns about what data are driving the decision making. And I just have concerns that, despite many strong efforts, we're still seeing a lot of disease and a lot of death. And I think to some degree, the state of Massachusetts owes itself a morbidity and mortality conference. In medicine, we have a tradition when a case goes wrong or when something is not well understood, that you kind of present to your peers and you closely review what went wrong, what are the reasons why this case turned out as it did, and it allows you to think about the factors that led you to be in the situation that you're in. So I think, we need to take a really hard look at what happened in our state, what continues to happen in our state that's really driving this ongoing pandemic, and why we have not been able to get it under control speedily. And, there's many reasons for that, but we need to understand them fully. And I think a few of them relate to what's been going on in our nursing homes. It relates to people who are marginalized and have not been able to participate in our efforts to control this. It relates to protections that we were or were not able to fully offer to essential workers. And it relates to kind of who in our society we decide to, who to protect. So I think really a hard look at what's been contributing to our ongoing caseload would need to be a piece of how we decide to move forward as well. Because if you don't address the problems that are driving this, it's hard to imagine that we're going to emerge and be in a different place. So those are some overview thoughts on opening. And I just feel like it's important to be sure that we are clear that it is a false distinction to say that we have to choose between our kind of economic activity and our response to the virus, because I think they go hand in hand. I mean, we're not going to have a thriving economy if people are dying, if your family members are dying, if people are afraid to go out and engage with stores or other settings where you could get sick. So I think that it's a false choice, and we have to have both. Somebody's asking a question about, can you tell us anything about the cases identified in children who experience severe inflammation related to COVID-19? Yeah, this is an interesting point that's been emerging in the last couple of days to weeks. I mean, I think as the virus has come to the United States, we've applied our medical eyes to this, and there definitely have been a number of observations that have come out in terms of what the disease looks like, and some of these observations are new. For instance, it's become clear that there are alterations in the coagulation and vascular systems, and so heart attacks and strokes seem to be associated. We've seen this emergence of an inflammatory syndrome in children. I think there's more than 100 cases in New York that have been identified of younger kids who have presented with something like Kawasaki's disease, which is a kind of multi-organ inflammatory syndrome that can occur in children. It's kind of a curious illness that can have a lot of long-term consequences for kids, and so it's definitely now being described in association with COVID, and we have had a handful of observed cases now in Boston as well. So these are the kind of things that are concerning, because with a new disease, there's new elements to it that we're learning about as we go. And I think the thing that's remarkable about the identification of this illness in kids is that, part of the narrative has been that And it's a happy part of the narrative that, younger people are less affected, but it will be interesting to see how this story plays out, because this type of inflammatory syndrome is something that may be related to other infectious diseases and can emerge kind of later on in the course. So I think how this plays out going forward will be interesting and important to understand in terms of risk for kids. So somebody's asking, what percentage of folks are getting the illness more than once? So, I don't think that we have any sense that anybody has gotten this illness more than once. There's no reports that I'm aware of that are credible on that front, but I think that the issue at hand is that, really we need to understand immunity to this coronavirus, and that is a really important piece of the picture here. We don't know if having infection once confers protection from having it again, and that is a really fundamental piece of biological information that we don't yet have about this virus. We do know that for other coronaviruses, like the ones that cause the common cold, they don't generally confer long-term protection, and people can get them repeatedly. This novel coronavirus, we just don't know enough about it yet. Certainly many viral infections, as we all know from our experience, you tend to be immune to them after you've had them once. So it's reasonable to be hopeful that that will be the case for this, but we don't know that. And it is on the table that it will not be protective for the long term. And so this is a really important piece of the biology that we have to understand and study. And it relates very importantly to how successful we will be in developing a vaccine and what the vaccine will look like once we have it. It may be a vaccine, if we have a vaccine, that has to be administered periodically and repeatedly, kind of like the flu vaccine that we're all familiar with. So we don't yet know. And I think this also relates very importantly to the issue of antibody testing, which has been much in the news lately. And maybe I'll just say a word about that. So just so everybody knows what an antibody is a protein that your white cells make in your bloodstream and other parts of your body that can bind or attach to a foreign invader like a virus. And it can be part of protecting you from that infectious agent. And it can be having those antibodies in your blood can be a marker that you've been exposed to that infectious agent before. And so right now there's been a lot of attention starting to be turned to tests to identify antibodies to coronavirus in people. And there's a couple of issues to understand about that. I mean, one, we don't know if having antibodies is protective. That's a really important piece of the biology. Secondly, there's been kind of just a scrum of different companies, many overseas, some in the U.S., but people scrambling to develop these antibody tests. And frankly, it's kind of a mess right now because some of the assays don't work as they say they work, and that's problematic. And then secondly, just interpreting the tests is difficult. And it certainly is not the case that people can assume that having antibodies means they're protected. And that's a really important thing to convey, because I think that there's been a little bit of a misconception that we know that. And it's so, antibody tests are hard to interpret in infectious disease to begin with, and they are extra hard in the context of what's going on right now with this coronavirus. So it's not the kind of test that people should be doing routinely without involvement of an infectious disease specialist, I will say, essentially. So there's a lot of complexities to that. So somebody's asking about A few friends have asked about having their long-time house cleaners return to clean with masks and gloves. Is there any time that you think this would be possible or safe, particularly now that the weather is better and household members could be outside? Well, I guess I just want to say, first of all, we are still under a stay-at-home advisory, and I would say that it's not appropriate right now to have people coming into your home to clean. I think going forward, these are the decisions that we have to make about how we drop the safeguards and begin to engage in some of the things we were doing before. To my mind, right now, I just feel like many of the people who do house cleaning have been the people who've been getting really sick with this, and I feel that there's an important responsibility to protect the people who work in our homes. And what does that look like? Well, for me, I feel very lucky that I've been able to have somebody help me clean my house for the last year. I've just continued to pay her even though she's not coming to our house anymore. I wouldn't feel comfortable yet asking her to come and clean my house, mostly because I want to protect her. We work in the healthcare field. I wouldn't want her to get exposed to us. So it feels premature to me to have somebody, doing kind of routine house cleaning for sure. Obviously, there might be special circumstances where people need help, but it feels premature to me on that front. Mostly because I'm worried about the workers. I suppose when the time comes to embark on that again, then we will need to be thoughtful about how to do it. And those will be things like separating physically and being sure that face coverings are worn and that gloves are worn and that, So somebody's asking, what are your thoughts about youth being together at camps, schools, and universities? Well, again, I think I would put this also into the category of this is a tough one to make a prediction about. I feel that it's an awful position for people, young people who've just graduated high school and might be looking forward to starting college in the fall. And, it's hard to predict what things are going to look like in the fall. And I've seen that some universities have announced that they will be open and that they're making plans to move forward with dormitories and on-campus teaching activities. But it seems like it's hard to make that prediction today, what it will look like in late August or September. So for the simple reason that people in congregate settings are the ones who have been getting sick, who have seen tons of transmission of virus. It's been impossible to contain in settings where people live together in close quarters, and that includes college dorms. So it's hard for me to imagine that there's going to be really any safe way for people to be living in congregate settings until we have a vaccine. And so that, we may acknowledge that younger people are perhaps less likely to have complications of illness, but they're going to be interacting with adults, older adults, and so we will need to have safeguards in place to prevent transmission between younger people and vulnerable other individuals like adults that teach them. So these are complicated issues, and I think it gets to the fact of why we really want to do our absolute best to take advantage of getting transmission under control now as best we can with the efforts that we've taken, so that when the fall comes, there might be some hope for a setting where we can educate young people, but it's not going to look like our current, I think, university campuses. I can't imagine how that would work. So somebody just asked again, is there any benefit of antibody testing? So just to go back to what I said, at this point, for the average person, I'll say the answer to that is no. I mean, there's no benefit because, number one, we don't know if antibodies are protective, so they don't mean anything in terms of you being protected. Number two, not all antibody tests are the same, and some of them are unreliable and uninterpretable. And number three, it's not really the standard of care for how you diagnose somebody with this infection in the first place. So I don't think this is something that people should be broadly accessing, and I would hope that it's not broadly available to anybody. We use it sparingly in our hospital now that we have an antibody test in our lab, but it has to be interpreted with incredible care, and it's not something that is a standard part of the testing repertoire. And so the answer basically is I can't think of any circumstance where just a kind of general person in the community would want to have antibody testing. It is a very important piece of how we will understand our general population level immunity, and it is a tool in the public health toolkit, which I hope that in coming months we will be rolling out and knowing more about, and our lab actually is working on that issue. But again, I think we all have to be really cautious about a lot of the unreliability of the tests that are available. And that's a really important piece. I think maybe I'll just say that one of the things that we've seen in the course of the pandemic is that the federal the Food and Drug Administration, the FDA, which regulates medical tests, has really been put to a big challenge here to make medications and tests available, and there's a real trade-off that has to be made with speed and with reliability and accuracy. So we're in our country, our medical system relies on having valid tests and safe medicines, and part of the reason we have that is because of the FDA, which has a very precise and careful process for testing and ensuring that tests do what they say they do, and that medicines are safe and do what they say they do. And so in the context of this emergency, there have been a lot of kind of relaxation of some of the bureaucratic requirements to get things out quickly to the public. But the trade-off has been that some things have gotten through that are not as reliable as they should be in terms of tests. And so I think the pendulum is swinging back the other direction. And that has applied a lot to a number of the antibody tests that have been made available. So I think that maybe I'll take one more question and then I'll wrap up. If antibodies are not effective as protection, this would mean we cannot have a vaccine, correct? I guess I'll just say that maybe it's a little more complicated than just that, because there's other components of protection against infectious diseases that are not just antibodies. But I guess the fundamental point is that we don't understand yet fully how the body's immune system responds to this virus. That's one really important thing that is we need to understand, and that people are working on right now. And so once you understand how immunity works, that enables you to have the tools to build a vaccine. So the understanding the biology of the disease, I guess, is a precursor, is a part of developing a vaccine. And a key point being that it's hard to make a vaccine for an infection that your body doesn't in and of itself develop protection to after an infection. So there's just some fundamental biology that we are kind of having to work out at the same time as we think about developing a vaccine for this. So somebody's asking, can you talk about how treatment protocols are evolving? What's working, what's not? So this is a really important question, and I think that we have learned a fair amount in the last couple of weeks about treatments. And I mean, I on the other hand, we still haven't learned that much. We've learned what doesn't work. We've definitely seen that some of the antiviral combinations, lopinavir, ritonavir, did not work. I think it's pretty clear at this point hydroxychloroquine does not work. And what we do know is that the antiviral remdesivir does show proof of working. All that being said, there's a lot of problems with this. First of all, we don't have much of it. There was a rollout of the medicine that was available from the manufacturer to hospitals throughout the U.S., and it was really very unclear what drove the rollout. A number of, just a handful of hospitals in the Boston area got the medication, and it was really unclear why some got it and others didn't. There was a really appropriate effort here in the state to distribute the available doses more widely to all hospitals, and that's been done. But the real problem we have is that we don't have enough of it, and we don't know who to give it to. It was announced that the trial done by the National Institute of Allergy and Infectious Diseases had shown that the medication shortened the duration of illness, but we haven't seen the data on the study, and so it's very hard to know who the people it helped were, and we're waiting for that information. I don't think that the data we have show that it's a real game changer in terms of people's recovery. It may be that as we give it to more people, we'll learn more, but it does have some benefit. The benefit is shortened duration of illness. But so we've got some real problems because we don't have enough of it. We don't have enough doses to even treat the people who are already in the hospital. It's really unclear what the pipeline is for getting more of it. So we need more medications to treat people with. The one that remdesivir, have shown has some benefit. We don't have enough of it. So this is a real challenge for taking care of people. It's a challenge for how do you equitably administer this limited resource. It's a problem. So I think I'll stop. I just want to, thank you for your attention. I'm, again, just representing myself. I'm not representing the institutions that I'm associated with, and I just wanted to share kind of a perspective from somebody living in your community. I just want to pause and say that, I think we should all remember that 5,500 people in our state have died in the course of the last couple of weeks, and it's a number that's almost hard to kind of wrap your head around. And I think I just want to share with all of you that it's good to think about what impact this has had on our neighbors and our people in the state, and acknowledge that everything we're doing is to help others. And I came across I was told about somebody's Twitter feed, which I think was worth looking at. It's Faces of COVID, and it's important to read the stories of the people who we've been losing to this infectious disease. So anyway, thanks for your attention, and I'm going to try to do this again next week on Thursday at 7. So I'll look forward to it. Thank you.